Assalamu alaikum, good evening. Welcome you all to our regular Zoom-based session of gynecological malignancy. Shorna, please add the participants because you are the only resource persons of today that you will have to add all the participants. Okay. I request at first before starting our session, as usual, I request our president of the sessions, our chairpersons, president of the Oncology Club, Professor M. Hai sir, to give us permission for starting the session. Sir, please.
Rahim. Thank you, Shana. Okay, we are already late by 11 minutes. Immediately, my heartiest welcome to all of you, particularly Annie Catherine. She could join us. Hopefully, she will stay with us the whole session. And thanks to Santosh Menon for giving them trouble too much. Our participants for learning something from you. Thank you all very much. Without any delay, let's start. Shana.
Thank you, sir. Thank you very much. Today, our learned faculty today is Professor Dr. Santosh Menon, sir. Shorna, please. Shorna. Yes. The topics of today's session is essential elements in understanding of the cervical pathology, which is necessary for all of our gynecology colleague, gyne-oncology colleague, and also the pathology colleague. And even after our busy casual, Professor Dr. Santosh Menon, sir, he become agreed to give the lecture on this session. I requested him, and sir, as you know, he's in a busy center. He is working even after that. So we didn't manage this series during our cervical cancer sessions, and from next week we will have the ovarian cancer session, but sir has agreed to give this lecture on today. Sir is the professor Department of Pathology and Uro-Oncology and Gynecological Oncology Disease Management Group, Tata Memorial Hospital, India. And we welcome you, sir, for giving us time, for your valuable time for giving these lectures. And we have too many participants from our pathology participants, the pathology colleagues, the gyne-oncology pathology, the gyne-oncology students, the gynecologists, that the cervical cancer, it is the most common cancer in this southeastern region. So we, all of us, will have to be accustomed to its pathology. And at last, we are very much happy that our president of the Oncology Club, Professor M. Hai sir, he is always with us and he gives us inspiration to do this session. I request Santosh Menon sir to start the program. Sir, please.
Thank you, Dr. Shahna, Professor Hai and Dr. Kamal for inviting me again. It feels very much like a family now. I've been a participant of Oncology Club meetings for several sessions. So I'll be speaking on cervical pathology today. A very good evening to Dr. Anne Catherine also. Can I share my screen, please?
Yes, sir.
So the topic for today is essentials of cervical pathology. I would be touching very little bit on the cervical cytology part. But before I start, I would like to declare that I have no conflicts of interest. And I have taken some images from the internet just for the pure purpose of education, and it in no way infringes any copyrights. So it's basically for education purposes, which I have used some images. As you know, cervical cancer is one of the most common cancers in women, especially in Africa and parts of India and Bangladesh and all. So we see a lot of cervical cancer. If you look at, before I enter the actual pathology part, I would like to highlight what the WHO is doing. I'm sure Dr. Anne Catherine would agree with me that there has been a big call from WHO to accelerate the elimination of cervical cancer. So this is the main goal of WHO in the coming years, and by 2030 they are planning to achieve a lot of goals, and they are working frantically in this field to eliminate cervical cancer as a public health problem. Just to put something in perspective, one woman dies of cervical cancer every 2 minutes. Each one is a tragedy. If you look at it, we can easily prevent it. We know that it's a cancer which is HPV related, which can be easily picked up in pre-malignant phases. It can be treated. We have vaccination now. So this is a cancer which no female should die because of this cancer. So that's a main objective behind the call by WHO. So what is the strategy of WHO? They are working on the principle of 90-70-90. They aim to vaccinate girls by the age of 15 years. By 2030, they propose that 90% of 15 girls by the age of 15 should be vaccinated. 70% of women should be screened by high performance test by the age of 35 years, and again by 45 years. And 90% women who have pre-malignant disease as well as malignant cancer should be treated adequately. So that is the goal on which WHO is working to eliminate cervical cancer. This is the proposal which WHO has put forth. Just to show the global incidence, if you look at these dark maroon ones, you can see that Africa, India, and Southeast Asia are the main countries where there's a global burden of cervical cancer lies. And same happens with the mortality. So like I said, it's a preventable disease, and there should be strategies to prevent this and treat cervical cancer in early stages so that there is the mortality rates are reduced. Coming to cervical pathology proper, if you look at my role or the role of a pathologist, it's basically in two things. That is the pre-malignant conditions or the cervical intraepithelial neoplasias. And once the patient has developed a cancer, to provide an adequate report based on which clinical people can intervene in a useful way post the diagnosis of cancer cervix. So I'll be going through this. What are the common specimens we receive in histopathology? So the common samples, like I said, I won't be going into the details of cytology because that becomes a completely different topic. So basically, when you have certain suspicious lesions on the cervix, the clinician would do a biopsy for this. If the biopsy report is CIN1, CIN2, CIN2, CIN3, then the clinician or the surgeon would go ahead and do a cone biopsy or a leap. And once there is cancer, a full-blown cancer, early stage cancer, then the pathologist would receive a resected specimen. So one must understand that a resection specimen means a radical hysterectomy specimen in CA cervix, and that arrives at the pathologist table only in early stage cancer of cervix. That is stage 1A and stage 1B1 maximum. So beyond that, generally, cervical cancers are treated by radiation therapy. So what are the pre-malignant conditions we are going to deal with? These are a couple of pictures from the IARC website. You know that a low-grade lesion looks very much like this, with thin nested white lesion with geographic margins. They may be skip lesions, they may be multiple lesions, and they may show fine punctation with irregular margins. So that's how low-grade lesions look on colposcopy and on physical examination. If you look at this, under the microscope, a squamous epithelium would have kind of this basal layer and then intermediate layer and the superficial keratinized layer. So this is the histopathology of epithelium of the cervix, with very dark looking basal layers. More cytoplasm is seen in the cells of the intermediate layers. And if you look at the superficial layers, they are flattened cells with more pink cytoplasm, which is called the early keratinization, the cytoplasm. So if you look at what happens in SIN1, the characteristic features are the presence of coilocytes. What do you mean by coilocyte in pathology? Is the presence of this hyperchromatic enlarged nuclei with irregular borders and perinuclear halo. I'll show you more pictures. Another sign which we pick up under the microscope is the presence of disc keratinocytic cells. So you see this very dark apoptotic kind of nuclei of the cell, along with a pink cytoplasm, very well-defined cytoplasm of the cells. These are called disc keratinocytes. This occurs when there is HPV infection in the cervical squamous epithelium. More pictures, better seen, large nuclei, irregular nuclear borders, hyperchromasia, and very nice perinuclear halo. There are abundant coilocytes in this. So this coilocytotic change is a very important cytopathic, viral cytopathic change which occurs when HPV infects the squamous epithelium. So that's how, as pathologists, we pick up a cervical intraepithelial neoplasia. Most of these are low-grade neoplasias, which correspond to SIN1. Many of them would occur with low risk also. So that's how we pick up SIN1 lesions in this. Coming to high-grade lesions, you see that they are more thickened lesions with raised borders, well-defined borders. This is a pre-acetic acid and post-acetic acid lesions. So these are the high-grade lesions which you are all familiar with. Most of the gynecologists familiar with. Again, the blood vessel pattern, mosaic pattern, because there is new angiogenesis, new vessels are being formed. So under the colposcope, you'll find this mosaic blood vessel pattern on examination. What happens when you take a biopsy from such lesions, which are thickened and white, aceto-white? Under the microscope, we see this very hyperchromatic and dark, crowded nuclei, loss of polarity in 2/3 to full thickness of the cervical epithelium. And that's why we diagnose high-grade cervical intraepithelial lesions. Another picture to show that you can see that the whole thickness. So this is the basement membrane of the cervical squamous epithelium. This is the top of the cervical epithelium. The whole cervical epithelium is replaced by very dysplastic looking cells. So there is loss of polarity. You look at the orientation of the cell, it is like this. Look at the orientation of cell, this is like this. So there is loss of polarity, there are mitotic activity, there is apoptosis, there is pleomorphism, and very bad looking cells throughout the thickness of the epithelium. And that's when we call this as Syn 3 lesions. So this is how a pathologist diagnose these lesions. So after a biopsy from the cervix, and when the pathologist has given a diagnosis of Syn 2 and Syn 3, the clinician would go ahead and do a conization or a leap. Mind you, these are important decisions that clinicians have to make, especially in the reproductive age group, bearing in mind that the patient is reproductive age group and may have a following pregnancy. So the minimal thing which they do is a conization or a leap when the diagnosis is Syn 2 or Syn 3. So handling of a cone biopsy or leap is very important. Generally, this is how you get the specimen. There is a thread which is put up at the 12 o'clock position. We cut open the specimen from here and we submit the entire cervix in clockwise position from 12 o'clock to again 12 o'clock all around. We take multiple sections throughout so that the whole cervix is submitted entirely. So this is very important. So when you have a leaf specimen, when you have a conization specimen, the pathologist should completely submit the entire cervix in a clockwise position. The important idea behind is that you already have a diagnosis of Syn 2 or Syn 3 on a biopsy. What are we intending to do on a cone biopsy? We are trying to see if there is invasive carcinoma anywhere. So is it a 1A1 tumor, 1A2 tumor, cancer within the leaf specimen or a cone specimen is the main idea behind the grossing of conization specimen. Again, picture to show that we cut open the whole cone, we divide it into multiple sections, and each section is submitted in clock position. So in general, a conization specimen would lead to around 25 to 35 to 50 blocks, 50 sections, which we have to ardently look at under the microscope to look how the Syn is present, whether there is invasive carcinoma or not. So like I said, the main idea in a leap or conization is to convey the presence or absence of stage 1A1 carcinoma. This may also be critical in dictating patient management. FIGO 1A1 neoplasms are often treated by local excision, ensuring that the margins are clear of pre-invasive, while 1A2 lesions and 1B1, we will come to the staging later, are usually treated with radical surgery. If the invasive focus is not present, then the information on the multifocality of Syn 3 is also important by the pathologist. So you may have a Syn 3 at 12 o'clock, you may have another Syn 3 lesion at 6 o'clock, another at noon. So these are multiple lesions which you see in all different clock positions. So that's the idea behind grossing the whole specimen of conization. And status of the resection margins is also important component of a report of a conization. The ICCR dataset guidelines have different algorithms or different ways in which you measure the 3 dimensions of the tumors. Once you submit the conization specimen, and if you see invasive tumors, you have to look at the depth of invasion. You have to see in which sections the tumor, which clock positions, is it multifocal, unifocal. So those things also come into practice of a pathology practice when you submit a conization specimen. Now, coming to the biopsy pathology of cancer, if you look at the 2020 WHO female genital tumor, there is a huge and long list of cervical cancers, including squamous, glandular tumors, and a lot of classifications, some benign lesions which are included in the recent WHO classification. But for practical purposes, the major pathologies which we encounter are squamous cell carcinomas and the adenocarcinoma. So most commonly 90-95% of the biopsy pathology or cervical cancer pathology would be squamous or adenocarcinomas. The other ones are the clear cell carcinoma, small cell neuroendocrine. This is very important to diagnose because the chemotherapy regimen may differ for a small cell carcinoma of the cervix. Then you have the rare, the sarcomas, and the malignant mixed Mullerian tumors. So the major histologies are squamous and adenocarcinomas. So a couple of pictures to show how we diagnose squamous. You look at this keratinization and they look like the squamous epithelium. There is a rip-roaring mitosis and there is invasion of the underlying. You may have necrotic debris and you may have apoptotic. You may have a lot of comedonecrosis in which you have islands of squamous cells with central necrosis. This is another picture, an old picture of squamous carcinoma, which was admixed with small cell carcinoma. So you can see that squamous carcinoma is highlighted by presence of this keratin pearls. So these round pink whorls are nothing but keratin pearls, which are part of squamous carcinoma, whereas this blue, very blue looking nuclei are part of neuroendocrine. So this was a rare case in which you had squamous admixed with neuroendocrine carcinoma. So these are the histologies which come across, and sometimes in these lesions, you do P16. You can see the nice P16 staining with the nucleus as the cytoplasm and the cytoplasm positivity in a block fashion. So the whole section is positive with P16, and that's when you call it a positive stain for P16. And there's a picture to highlight the nuclear as well as cytoplasmic positivity. Now, I want to highlight a couple of things in the recent WHO which have come up, and this is related to the IECC classification, which has been a paradigm shift in the diagnosis of endocervical adenocarcinomas. So what has the major shift been, or paradigm shift in this been? It has been that the diagnosis of endocervical adenocarcinoma is now divided into HPV associated and HPV non-HPV associated tumors. And the best part and the beauty of this classification is that the diagnosis is basically based on morphology. So under the microscope, in an adenocarcinoma, if I see apical mitosis and a lot of apoptotic tumor nuclei, I am pretty sure that I'm dealing with an HPV-associated cancer. So you don't need high-fi fancy tests, although if available, you have to do a P16 and HPV in situ hybridization to pick up the HPV. But based on morphology, apical mitosis, and presence of apoptosis, you call it an HPV-associated tumors. And then based on other cytoplasmic features, whether presence of mucin within the cell is there, you have to divide into further. So the basic understanding you need to understand now about the WHO adenocarcinoma classification, they are divided into HPV-associated and non-HPV-associated tumors. So these are easily identified, like I said. Is it just a morphological classification? So there have been publications, various, again by the same group from Europe and other area, and in US, led by Simona Solnicu in Romania. They have looked at the clinical outcomes of HPV-associated and unassociated endocervical adenocarcinomas, and they have clearly shown the difference in overall survival, disease-free survival, as well as progression-free survival between the HPV. So the HPV-associated adenocarcinomas are picked up at an early stage. They do well as far as disease-free as well as overall survival. So it's not only a morphological classification, it has got serious clinical implications and prognostic implications in the tumor. Another pathological part which is important, which most of the pathologists are not aware and do not use, once you have a diagnosis of adenocarcinoma, you need to look at the pattern of glandular invasion into the stroma. So there is something called a Silva pattern, which is again developed in the US, based on the grouping of the glands, how closely the glands are grouped together. They are divided into pattern A, pattern B, and pattern C. The most important thing about this is the pattern A tumors almost never metastasize to the lymph nodes and distant. So it is important to sift out this pattern A adenocarcinomas from the pattern B and pattern C, because the incidence of nodal metastasis is minuscule to negligible in pattern A tumors. The problem with this, in a given biopsy sample, it is extremely difficult to give the pattern. So it's only on a resected specimen that you would be able to give this Silva pattern in an adenocarcinoma. So what happens after a biopsy diagnosis? If it is an early stage cancer suspected by the clinician as well as on MRI findings, surgery is the mainstay of treatment for cervical cancer. So that brings us to the FIGO 2018 cervix staging, which is extremely important. There have been certain changes, and you can see this is a long list. Everybody knows this. You can go back and go and read the staging of cervical cancer. There have been certain changes. So I will just highlight some main changes which have occurred from 2009. So the horizontal dimension of 7mm is no longer considered defining the upper boundary of stage 1A carcinomas. Stage 1B has been subdivided into B1, B2, and B3 based on the tumor size. The nodal status is included in the FIGO staging, and stage 3C means that the nodes are involved. 3C1 means that the pelvic nodes are involved, and parotid is 3C2. So prior FIGO staging were mainly based on clinical examination, but in 2018 FIGO staging, it allows imaging and pathology findings to be taken into account, and they use the prefix R and P for staging of FIGO. Coming to stage 1 cancer, more carefully, we'll go into the details of this. The stage 1 is divided into 1A and 1B. The 1A is based on the depth of stromal invasion less than 3mm, and any stromal invasion by the cancer between 3 and 5mm in depth is 1A2. So it's so important to accurately pick up these things and accurately diagnose this so that the management is tailored accordingly. Coming to 1B, you have 1B1, 1B2, and 1B3 based on the tumor size of between 5mm and 2 cm, 2 to 4 cm, and more than 4 cm, the greatest dimension. So just a pictorial representation. We no longer use the horizontal the extent of the tumor. It is basically based on the depth of invasion by the cancer into the cervical stroma, 3mm and 5mm being the cutoffs here. If you look at 1B, the 1B1, again, pictorial representation to show the 1B1 is between 5 to 2 cm, 5mm to 2 cm, 2 to 4 is 1B2, and more than 4 cm is 1B3. So is there evidence to divide? Why did FIGO go ahead and divide stage 1B2? So they have shown, there are several studies. I have put in some of the references here. They've shown that the FIGO stage 1B1 cervical cutoff of 2 cm may be of prognostic value. And they've done several studies to show that 1B has to be segregated into 1B1, 1B2, and 1B3 neoplasms. Coming to stage 2 is again divided into 2A and 2B, and 2A has got 2A1 and 2A2 based on the dimension again, with and without parametrial involvement or vaginal involvement. So when we get a specimen of cervical cancer, a radical hysterectomy specimen, what is the pathologist's prerogative in this? We have to accurately measure the dimensions. Like I said, the stage depends on the dimensions of the tumor, the depth of invasion, the size of the tumor, taking appropriate recommended sections. So that is extremely important. You just cannot do away with this grossing of the specimen. You have to take adequate sections at grossing so that you include the greatest depth of invasion, the big tumor size, the distance, the margins. All those things are part of protocols and guidelines, which are readily available in various guidelines like the CAP guidelines, the ICCR data sets. I'll show you some pictures. So this is a hysterectomy specimen, which is showing a cervical cancer, large cervical tumor. So this is the tumor, and this is the maximum depth of invasion of the tumor into the cervical wall. This is the distance of the tumor from the adventitial cut margin, and you have, this is the posterior vaginal wall and the posterior vaginal margin, and the tumor appears to be at a good distance from the vaginal margin. So you have to take adequate sections of the tumor, the maximum depth of the tumor in a section, the tumor's distance from the adventitial margin. There have been several studies to show that if the tumor is very close to the cervix, especially 1 to 2 millimeter, then the chances of recurrence and the vault are high. So that's important. And then you have to take all the vaginal cut margins properly and document the margins. So these have been part of the European Society of Gynecology quality indicators also, that pathologists should be a part of decision making, and pathologists should also aid in the management of cervical cancer. So these are some of the points which are included in this quality indicator. You see that how most of the points include the histological tumor type, tumor grade, presence or absence of LVSI, minimum distance. So in a nutshell, the salient points in grossing are tumor dimension, vaginal involvement, the length of the vaginal cuff and the distance of the margins from the tumor, and the depth of invasion on the gross, and the distance of the tumor from adventitia. If you look microscopic points, you have to type the tumor, whether it's a squamous carcinoma or adenocarcinoma or a neuroendocrine carcinoma. Size, we have already discussed in great detail why the size is important, because it's part of the staging. Depth of wall invasion is important. Distance from adventitia. LVSI is extremely important. Many of the pathology reports which we come across do not mention, and this is important for decision making, whether to give adjuvant radiotherapy or not to these patients. Vaginal involvement, the cuff margins, and the parametrium. So these are readily available in ICCR datasets, RCPath guidelines, and the CAP datasets. They are freely available on the websites, and you can download and use them in your practice when you are browsing the specimens. So this is just to show the ICCR datasets. It is all tick box kind of guide which are provided, so you can easily use them in your practice. A word about the margins and the recurrence rate. You can see that in a couple of studies which I've highlighted here, the local recurrence rate was 20% when the margin was closed. The margin was closed less than 1 centimeter. In the same study with negative margins defined as clearance of more than 1 centimeter, the recurrence rate was 11%. So there is a difference in the recurrence rate. And as a pathologist, you need to document how far are the margins from the tumor, and whether you take adequate sections at microscopy, and see what is important in this. Do you report dysplasia? Where we regularly report dysplasia at the margin. So you have vaginal cut margin. Sometimes the SYN 2, SYN 3, or the pre-invasive neoplasia is seen to involve the vagina and vaginal epithelium up till the margins, and it's a required element in the report which we usually report. Coming to a bit about lymph node grossing and microscopy. So lymph node status is one of the most important prognostic factors, and the 5-year survival decreases from 85 to 50% when there are lymph nodes are identified. So like in any other cancer, once the tumor has gone beyond the confines of the cervix and gone into the lymph nodes, the survival decreases. So it's important that we know about a little bit about lymph node grossing, little about sentinel lymph node and all that as pathologists. So resected lymph nodes are categorized as regional or non-regional. And like I said in Figure 18, 2018, pelvic lymph node involvement is staged as 3C1, and para-aortic nodal involvement is stage 3C2. The chances of nodal involvement are in different stages are different. So you can see in stage 1A1, it is less than 0.5%, whereas it increases to 12 to 20% as the tumor size increases, and the chances of metastasis increase, and you have 12 to 20% nodal involvement in this. A little bit of word on sentinel lymph node, why it may be done. So a sentinel lymph node biopsy is of value in reducing the requirement for complete lymphadenectomy. So if you do a complete lymphadenectomy in the pelvis, the chances, the morbidity of the surgery increases. There is lymphedema, there is lymphocele, collection of lymphatics. So that's important that sometimes in certain very early cervical cancers, the surgeon would send you sentinel node for frozen section to look at whether there is a micrometastasis or not. Because there are chances of micrometastasis to up to 10% in certain studies, even in early stage cervical cancer. And they sometimes do influence even the micrometastasis with prognostically significant, and many studies have proven that. So how you process this, I don't know whether in Bangladesh it is very common to do frozen section. Dr. Shahana, do you do frozen section very commonly for sentinel nodes, or is it a practice?
No, sir. We are not practicing sentinel node in cervical cancer, but frozen section is available there in different centers.
Okay. And Dr. Anne Catherine, do you do for cervical cancers sentinel lymph node?
No, not so much. Mostly just for endometrial cancer. We usually do a full node dissection. Yes.
Yeah. So we also don't do it very regularly. It's only in very early small cancers. Sometimes we would receive a sentinel node at frozen section. And obviously we take 2 or 3 sections to look at if there is any metastasis. But on final histology, the sentinel nodes have to undergo a very long procedure. You have to cut multiple sections and multiple levels. You have to do cytokeratin stains to look for micrometastasis. So it's not a common practice in most parts of the world to do sentinel node biopsy in cervical cancer. But in very early cancer and good risk cancer, sometime you would want to do those things. So coming to the very important slide of why we are doing all this grossing, why are we looking at margins, why are we looking at LBSI? So as pathologists, you are in the driver's seat to risk stratify the patients. So if as pathologist, your report says deep stromal invasion, more than half the cervical stroma, if you say the tumor size is more than 4 centimeter, if you say there are LVSI, these patients would fall into intermediate risk category by Sedlis criteria, and they would receive adjuvant pelvic radiotherapy. So you see, supposing you miss out on LVSI, supposing you don't document the deeper stromal invasion, the patient misses out on a very important part of the therapy for cervical cancer. So as pathologist, it's your prerogative and it's your arduousness which makes the report look good, includes all the important points so that the patient undergoes the correct therapy. The high risk features include positive lymph nodes, positive cut margins, and parametrial involvement. So these patients would probably receive adjuvant concurrent chemoradiotherapy. So that's the highlight of this. So it's not that we are doing it for the sake of doing. As pathologists, you play a very, very important role in the adjuvant management in case of CS cervix. I think I have a very short talk, so I would like to take questions. I would like to thank my colleagues, Dr. Kedar and Bharat, and my clinical colleagues. I can't thank Dr. Amita enough, Dr. Jaya, Shaila, Sri, Seema, and the residents and technical staff. I haven't gone into too much details of individual cancers. If you have any questions pertaining to that. So this was more like a practical application of how and what to be seen and what is important in pathology report, and how you become a part of management team, and how the clinician looks forward to certain points in your report which are important for adjuvant management. I'm ready for some questions. Dr. Shana?
Yes, sir. All the participants are requested. If you have any questions, you please put them in the chat box so sir can answer. Now we have the one of our renowned the well-wisher, and always she gives us courage and inspiration. Dr. Rupendra Shekhar ma'am, she is with us. I request Dr. Rupendra Shekhar ma'am to comment on today's presentation. And if you have any question, please ask Rupendra Shekhar ma'am, please. And Shorna, please.
Yeah, thank you, Shana.
Yes,
as usual, it was an excellent presentation by Santosh. One can never fault it. And the more one listens to Santosh, the more you keep learning. So
Thank you,
I
ma'am.
really, so I really have don't have too much to add, except that, you know, when it comes to the intermediate risk factors, sometimes we are not too happy giving the patient EBRT as well as ICRT. And we do feel that we are over treating the patient. Because what happens is that sometimes the size of the tumor might be small, but there would be LVSI or there would be deep stromal invasion, especially when the cervical cancer occurs in the elderly. See, there, as it is, the volume of cervix in the elderly is very less.
Yes.
So even a small lesion would, you will have a stromal invasion and all that, and one is not very sure that whether they will be able to tolerate EBRT so well. When it comes to the younger people, as it is in surgery, we would have removed 2-3 centimeters of the vagina. So this will shrink further after we give them ICRT. So definitely the sexual function gets impacted in such cases also. So even though Sedlis criteria is there and all that, I would still suggest to everyone to be very, very judicious when you are offering adjuvant therapy to patients, especially of the intermediate risk factor. See, of the high risk factor, there is no doubt. If your margins are positive, nodes are positive, they definitely require aggressive treatment. But one can perhaps be a little more judicious when giving the RT to the intermediate risk factor. Thank you.
Thank you, Dr. Rupendra ma'am. Thank you. I had just one point for discussion. You see, we have so many, this depth of invasion, the tumor size. Are there studies, maybe Dr. Anne Catherine can also help in this. There is a sure shrinkage after formalin fixation of the tumor, of the whole specimen for that matter. So formalin shrinks the tumor, shrinks the specimen to almost 1/3 the size. So there is a reduction in the size of tumor. So are you bothered about the staging in such cases? Do you understand? So supposing I say after my grossing and after my report, I say it's a 7 millimeter tumor. or a 5 millimeter tumor. So do you take it that after shrinkage it is 7 centimeter? Do you sometimes consider this? But this has always come to my mind, although I am not very well versed to say, but there is always a shrinkage in tumors, and it's so important to pick up the tumor size in C cervix.
So first of all, that was a really excellent presentation. Thank you so much. And I am again struck and humbled by, as a clinician, we are only as good as our pathologists. And truly, the decisions that we make are totally guided by pathology. Radiologists as well, but I think pathology completely, because first for surgical decision-making and then for post-operative decision-making, we're completely reliant. In terms of the issues of the size of the tumor, like 5 millimeters versus 7 millimeters, that's a difficult one. I mean, I know we do have a fairly robust body of information that shows us the risk of spread based on size. I think for cervical cancer, even more than potentially many other cancers that we deal with. I mean, to take ovarian cancer, that's a completely different discussion. But in cervical cancer, you know, vulvar cancer would be another example of the situation where millimeter by millimeter, there's a difference in risk of lymphovascular space invasion and travel. And so it probably does make a difference on some level, especially in the setting of, say, fertility sparing. So say you did a cone biopsy and you had these particular issues, you might make a different decision in how you counsel your patient millimeter by millimeter. In a post-operative radical hysterectomy specimen, I suspect that's probably less important, because there we're more interested in the other factors that you brought up, such as, you know, where are our margins? How much, you know, how deeply invasive in terms of the closeness to the margin, and is there actual pelvic spread? I'm curious, actually, if Dr. Kamal, sir, if you would comment on that too, in terms of your post-operative considerations.
Thank you, Catherine. I think it is a very intelligent issue that brought out by Santosh. But all the parameters that we have been studying, these were all on this gross and this shrinkage tumor size. So whatever data that we are now generating, say, let us take it that originally the tumor or something, by shrinkage process, it has reduced by 10% or 15%.
30%.
Sorry. So all the data generated by the paper is based on this type of same grossing. So I think even there is some shrinkage, but our decision is made on the same outcome. So probably this may not impact on our total decision of treatment, because these are based on some literature which was done on the same type of pathological data, pathological report that has been generated as from those.
Yeah, I would agree with you, Dr. Kamal, sir. I would agree with you. Rupinder, madam, any comments on this?
No, I also absolutely completely agree with what Kamal has said, and also what Catherine has said. We just have to, you know, account for the 10% shrinkage, and just have, like I have already commented that, you know, it's very difficult to actually categorize that this one is she's a slim patient, and this one the BMI is this much, and so the cervical, and that age is this much, and the cervical length is this much, and all that.
Yeah.
We have,
Yeah, I think as gynae oncologists, the difficult decision making is when you're looking at fertility preservation.
Yeah, absolutely. So fertility preservation, sexual function preservation, and if the patient is young, you don't want her to live with an abdominal discomfort caused by EBRT for the rest of her life. You know,
Yes.
you don't want her to you don't want her to be coming back to you again and again, and you offering soft diet to her and all that. So one has to be a little judicious when offering adjuvant therapy.
Yes, we have our pathologist colleague, Dr. Farida Anjuman. Shorna, please make co-host Dr. Farida Anjuman and another pathologic colleague from Army Pathological Lab, Dr. Joinul Abedin. Please make these two persons co-hosts so they can ask their question. Dr. Farida Anjuman.
Thank you, madam.
Yes, thank you. Dr. Joinul.
Good evening to Professor Santosh Menon for your nice presentation. My query is one. I already wrote it in the chat box. As you mentioned about the silver pattern of reporting in adenocarcinoma of cervix, there was type A, B, C. We actually not mentioning anything during our reporting. So is it mandatory to report whenever we report adenocarcinoma of cervix? And what is the clinical importance of that?
Yeah, so like I said, it's difficult to do it on a biopsy specimen because the biopsy is fragmented, and most of the times you end up giving a diagnosis of adenocarcinoma HPV associated versus non-HPV associated, especially the gastric type of non-HPV. The issue is when you have a resected specimen of adenocarcinoma where you're seeing the glands invading the stroma, you should try and give the silver pattern, because like I said, the clinical implication of a silver pattern A is that there is almost negligible to very, very minuscule chances of nodal involvement in silver pattern. It increases with silver pattern B and C, the chances of nodal involvement. But in most cases of CA adenocarcinoma of cervix, I think the clinician would already do a lymph nodal dissection in many cases. But there have been studies which say that silver pattern should be included as a part of your report. But like I said, in a small biopsy before the surgery is being planned, it would be very difficult to comment on silver pattern.
So for the large specimen, we should note it.
Yes, we should try it. Again, there is inter-observer variability in this, and I think the kappa scores are just about moderate agreement. In various studies, they've showed that there can only moderate agreement between various silver patterns.
Okay, thank you very much.
Thank you.
Joinul sir, please. Joinul sir. Have you any questions, sir, please? Joinul.
Thank you, Dr. Santosh.
Thank you.
Yeah, for a very nice and elaborative presentation. In fact, sometimes we encounter, if you say, I don't know, you face this sorts of problem or not. We get the specimen, divided specimen. It's a hysterectomy specimen, but it has been divided to many parts and going to different pathologists. So it's become very, very challenging to do the staging and then to even to find out the resection margins. So how far you face these sorts of problems?
Thank you, Dr. Islam, for your question. So we receive a lot of referral material, and sometimes the referral material is very limited. Like you said, we get 2 blocks of a tumor. So you see, if you get limited material, you can give only limited information, and you have to have the whole specimen with you. So what I did, I told you ideally about the specimen is an ideal report when you have the whole specimen coming to you, and you can look at the margin and see. If the specimen or the blocks are not correctly labeled and submitted to you, I really don't think you can go too much far stretching your neck in that. So the point is, if you have got limited material, we try to give as much as possible in that material, but then there are certain limitations which are always going to be there. So this practice of dividing the specimen and sending to various labs occurs even in India at many centers, especially in small private labs. They do this. They have tie-ups and all. But in general, for the specimens which come from outside referral are usually full specimens, or we get the relevant blocks very well labeled to us.
So, and in fact,
Hello, I think we lost you.
Yes, sir, probably. So there is a question. There are some questions in the chat box. Probably Dr. Joinul, he will join again. And before that, we want to discuss on that. There is a question that from Dr. Jannatul. That is, how frequently do you perform dual staining?
Dual staining for?
Yeah, I don't know. Dr. Jannatul, the presentation.
Dual staining, I think she means on cervical smears, probably
yes.
P16 and MIB1.
Yes, maybe cervical smear. Yeah.
See, our cervical cytology is pretty well developed. We do LBC in certain cases, but not as a usual routine, because our cyto department, the amount of inadequate smears is very less. So we get good smears, and we are not doing it in routine practice to do P16 and MIB1 double labeling for. So we did it as a part of a project with NCI. Dr. Kedar the other was a principal investigator, and we did find the results to be very not very good in that, but there were certain cases where we could do the dual staining and find the. So it's not done in routine practice in dual staining, cervical staining.
So there is another question from Vijay Kaur, that is, what ISC markers to be used to differentiate between endocervical adenocarcinoma and adenocarcinoma of the lower uterine segment?
Yeah, that's a good question, Dr. Bijoy. And I think we use a panel of CEA P16, which are positive in endocervical adenocarcinomas. And we use Vimentin for endometrial adenocarcinomas. So CEA and P16 are good markers for endocervical, because endocervical adenocarcinoma, many of them would be P16 positive, and most of them are CEA positive. But like I said, sometimes it may be difficult to distinguish these two, even based on these markers. And usually endometrial adenocarcinoma, especially the low-grade ones, would be nicely and diffusely positive for estrogen receptor, whereas usually endocervical adenocarcinomas are negative for estrogen receptors. So a combination of P16, CEA, ER, and Vimentin usually help us in diagnosing these, distinguishing these.
Another question, how could we differentiate severe dysplasia and CIN3 from carcinoma in situ? Or
So in general, these terms are pretty much used. Sin3 and squamous carcinoma in situ are generally used interchangeably in most cases. The implications are similar. A Sin3 lesions is basically a carcinoma in situ, squamous carcinoma in situ only, and the management decision would be similar in both these cases. So the problem comes for the pathologist to label as an invasive cancer. I think that's the question you want to ask. So supposing I have the information that there is a 3 centimeter, 4 centimeter tumor, and it has involved the parametrium on radiology, and I get a small biopsy which shows a Sin3 lesion. I don't see a typical invasive focus in the small biopsy, but putting together the clinical picture and the radiology, I would put it in my report that given that the radiology shows a parametrium, this is consistent with an invasive squamous carcinoma. So that's how I would word my report. And that looks more prudent because you already have information on the parametrium involvement in such cases.
it's true, sir. Sometimes it is told that it is carcinoma in situ, but as you know, the patients are so much, they are so much, curious about their reporting, so they take the specimen from different laboratories, and sometimes see it is CIS, somebody is written it is CIN3, and they have too much.
So pretty much similar. Dr. Shana, you would agree with me that SIN lesions are generally flat lesions. They involve the thickness of the endometrium, of the cervical squamous epithelium. And so if you have a grossly visible lesion seen by a gynecologist, which is like a cancer, and you get a small biopsy which shows Sin3 or squamous carcinoma, so we are basically dealing with an invasive cancer. So that's the practical point. So I think patients should be counseled that you have a clear-cut growth. You have a growth which is involving the parametria or involving the vagina. So even if the biopsy says Sin3 or squamous carcinoma, we are dealing clinically with an invasive squamous carcinoma in that case.
Very right. Many times we are faced with this kind of a dilemma, and we have to, convince the patient that, see, this is what the imaging is also saying,
Yes.
and this is what are our gross findings, and basically we are dealing. But there are a few instances where we have to do a rebiopsy and get a report out and out.
Exactly.
Santosh, I have a question, technical question to you.
Sure, sir. Sure.
So somebody has taken a biopsy. CT is 1 centimeter. Then excision was done. Surgery was done.
Mhm.
And now the tumor is say something around 3 centimeters.
Mhm.
So for staging purpose, are we going to add both the size together, or I mean the remaining part? How we are going to deal this type
So,
of
sir,
tricky scenario?
this is a difficult question to answer, sir. So, like I said, we don't receive specimens which have large tumors. Like I said, a radical hysterectomy is generally done for tumors which are maximum. I think 1B1. Dr. Rupinder would agree with me. We don't operate high stage tumors in CS cervix. So, in general, like you said, if you have done a conization for a SIN3 and you have found a invasive carcinoma, we don't use the word microinvasive carcinoma anymore. We call it stage 1A1 or 1A2. So I think that would stop at that. And suppose it's a 1A2 tumor, and then you do a radical hysterectomy, or say 1B1 tumor on a SIN specimen, then do a radical. I don't think that would add up to it. So the cutoff here, what we are talking is hypothetical, I would say. And in general, such a clinical situation does not arise.
Yeah,
in clinical
Santosh,
situations.
I totally agree with you. But what I am talking, say, this in periphery area, somebody just take a biopsy, and then they land up
So
in a
we don't add up
situation.
the biopsy size to the
Yes,
tumor.
that is
We
my
don't do.
message. Is
We
we
don't
should
do.
shall we add the biopsy
Because
size or not?
biopsy is a very tiny specimen, 1 to 2 millimeter, and we call it squamous carcinoma and that. And the final specimen, I don't remember anybody talking about it or adding it, or I don't know if there is literature in which the biopsy size is added to say a SIN specimen.
Oh,
Absolutely.
thank
I agree with you on that, Santosh. We do not have biopsy size.
Any more questions, Dr. Shano?
No questions in the chat box.
I thought of keeping it very small. You have given me 90 minutes. I don't think anybody can speak for 90 minutes. So I thought I would keep it a very practical kind of implication. I think what pathologists lack in most areas is how they form a part of the team and how their reports matter to the clinician. That is very, very important. So sometimes you break your head over moderately differentiated squamous carcinoma versus poorly differentiated. I don't think that matters at all to the clinician. I have never had a call from Dr. Amita saying, "Could you tell me the grade of the tumor in CA service?" So grading is not a required element if you look at it. So pathologists are fraught with these things. What is more important is picking up the LVSI, picking up the depth of invasion, looking at the margins. So those things are more important and matter more for the patient as well as the clinical situation.
Santosh, I have to compliment you. Your clarity amazes me. It's absolutely fantastic.
Thank you so much, man. Thank you.
Santosh, I have another question.
Sure, sir. Sure. Please go
When
ahead.
the pathology is adeno in cervical cancer, so I mean in squamous we know, but is there anything special that you want to focus that for the pathologist, the clinician,
yes,
that we need to be?
So that's why I clearly so sure. After WHO 2020, it is now very clear that we need to distinguish HPV associated adenocarcinoma because they do very well compared to non-HPV adenocarcinomas. The non-HPV includes a gastric type of adenocarcinoma, which are extremely difficult to diagnose, first of all, because they look innocuous on a small biopsy. They look like some glands which are just probably here and there scattered, but they're actually deeply invading. They may present at very high stage. The chances of their recurrence are very high, and distant metastasis is also high. So when you are dealing with an adenocarcinoma cervix, the most important thing is to distinguish HPV associated versus HPV not associated tumor. And the best part is you can pick this on morphology. If there are pathologists in the audience, if you see a lot of mitosis, apical mitosis and apoptosis under the microscope in an adenocarcinoma of cervix, you are dealing with a HPV associated adenocarcinomas. If you have a P16 in your lab, you can do a P16 to confirm the HPV. And if you have high-end tests like RNA in situ hybridization, you can even subtype these tumors sometimes with RT-PCR and this fish. So the important message in adenocarcinoma is to distinguish HPV versus non-HPV adenocarcinoma, because the prognostication differs in these two tumors.
My question to Rupinder: are you still a favor of surgery in adeno, or more in favor of adeno like the Japanese, or you prefer to deal squamous adeno same?
No, we would definitely err on the side of doing surgery, even if the tumor is larger than 1B1, if the histopathology is an adenocarcinoma.
Yeah, that is what I'm telling, that adeno, we are going for more a surgery than radiation for this. I mean,
Absolutely.
all through it's shown better with surgery compared to radiotherapy in adenotype.
Yeah.
And you
Yeah,
would
So what is the
you would do a
cutoff,
lymphadenectomy also, Dr.
Dr.
Rupendra, you
Rupendra?
would do a lymphadenectomy also in these
Of course.
adenocarcinomas.
yeah. We do a lymphadenectomy also, definitely.
So Dr. Rupinder, what is the classical cutoff for adeno cervical that you go surgery beyond, I mean, 1B2 also, normally?
So there isn't any specific cutoff for, say, adeno as such, that if it is adeno, so the cutoff will be this much, or that if it is squamous, the cutoff will be this much. It is not that. It is just a randomization that for a, say, a 1B2 tumor, if it is squamous cell carcinoma, I would definitely give it to my radiation oncology colleague. However, if it is an adeno CA, I would, and if I think the parameter is soft and so on and so forth, I would definitely prefer to do surgery.
Sir, what is the message for our pathology colleagues in case of adenocarcinoma for their reporting? In short, please, sir.
I think I've already
Sahana,
taken that
there is a
question.
question in the chat box. Sahana, there is a question in the chat box.
Yes, I'm saying.
Asha Kumari asked a question.
How? Yes, Asha Kumari. How to differentiate MEBSCs and CSRBs?
Oh, I think we are totally dealing with totally two different things. MEBSS is an infective condition and CS cervix is a malignant condition.
Yes.
So I don't remember seeing a cervical MEBSS in my life. MEBS is something which resides in the colon. Sometimes these amoebae may, through fecal contamination, reach the vaginal canal and cause infection. So I really don't know how to answer this question because the malignancy is completely different from an MEBSS. I don't think that's an issue as far as pathology is concerned.
Yes, I have seen that, so I didn't ask it.
Any more questions, Dr. Shana?
Yes, somebody is asking that they want to get a endoscopy training via online. Yes, we are not.
I'm not the right person probably for that. Yeah, of course.
Yes.
I think there are no further questions. Maybe we can conclude the session if there are no more issues to be
We
sorted.
have no other questions. But before that, we have some poll questions. We want to show the poll questions so that our colleagues can answer.
Okay.
Corner, please show the poll questions.
I think everybody knows the answers to this question.
Yes, sir. What? 40 seconds, 35 to 40 seconds from a per question. Yes.
Question is fairly simple.
There are so many general gynecologists with us. So usually we try to put them.
That's fine. There's a pleasure in answering simple questions.
Yes, yes, agree. Bindu ma'am, are you doing PDL1 in many cases of CA cervix? If I may ask, PDL1
Yeah, some very, very few.
in metastatic setting.
Yeah, very, very few. We've
Very
had,
few.
we had a couple of strange cervical cancer tumors. They presented with metastasis to the brain,
Okay.
single metastasis. So that is where they did do a PDL1, just to figure out, which was quite, the patient had presented with several cerebral metastasis, cerebellar metastasis. So she had
Okay.
actually presented with ataxia and all that. And surprisingly, there was nothing else anywhere else.
Yes, likewise, we've only been doing PDL1 for recurrences after primary therapy, Taxol, cisplatin, bevacizumab is sort of standard recurrent treatment if someone progresses. Same with vulvar cancer, that's the setting where we've been doing PDL1. I can't say I've had enough patients on pembrolizumab or immunotherapies to know that it's made a difference. I had one patient with endometrial cancer who had receptors and had a complete clinical response to immunotherapy. It's really very anecdotal.
Yeah, I agree with you on that completely. We have had very few patients on pembrolizumab, and I distinctly remember one who was in the ICU for so long that she finally somehow the attendants took her away. It's not that she got well. Yes, giving pembrolizumab is actually anecdotal even for us.
So if we have no other questions, there is a nice discussion, a nice presentation from the pre-invasive disease to invasive carcinoma cervix, how the reporting in case of the leaf and also the conization, and sir has uttered the things that we must, if we do the conization and leaf, we must do the margin, how the margin should be identified and in what position, either 12, 6 or 3 or any other position, so they can identify the margin. And also sir had, and it is also important in case of conization to know the invasive disease or not, and also the immunohistochemistry of the reporting in case of cervical carcinoma, and also whether in adenocarcinoma it is either it is SPP associated or endocervical in adenocarcinoma, and everything, and is briefly sir described this, and we are very much grateful to Santosh Menon sir, and we request sir in future we want to hear from you about the endometrial carcinoma.
I will do that, Dr. Shana. I promise I'll take endometrial sometime.
Yes, sir. Yes.
Sure.
Thank you, sir. Thank you very much.
Thank you. It's been a pleasure being here.
Yes.
Yeah, thank you so much.
Thank you, Dr.
Santosh.
Rupinder. Thank you, Dr.
Thanks,
Ann. Thank you. Good night. Yeah.
Thank you, sir. Before ending, I request Dr. Kamaluddin, do you like to comment?
Dr. Kamal and Dr. Hai.
So nothing to comment. Giving thanks to Santosh, no need, because he is a member of our oncology club. So give us more time, Santosh. We want to be enlightened by your lecture more frequently. That's all.
Sure, sir. Sure. I'll do that, sir. I'll keep that in mind. Definitely. Thank you so much. It's a pleasure.
One question in the last, is there any molecular marker for recurrent carcinoma cervix?
Molecular marker in the sense to pick up carcinoma recurrence?
Recurrent, yes.
Or you mean to say targetable therapy, maybe? She means to say targetable.
That may be.
So like in all solid tumors, these days, the fashion word is next generation sequencing. So I don't think there is a specific marker for CA cervix or there. So you can do NGS and you may find some targetable lesions, especially in certain adenocarcinomas, you may have HER2 or something which is expressed by that tumor. And then you can target them with the required targeted drug. I don't think, Dr. Ann, do you think there is a specific marker for CA cervix? I don't think there is a specific molecular marker, except for HPV associated B16, which is like diagnostic as well as.
So I request Thank you, sir. Thank you very much for giving us the time, and our students, our colleagues, and also the gynecologists. As today is the first day of our changing, and from today, in next days, we will arrange this program on Sunday. So all the participants are requested to attend on Sunday, and keep in mind that it is the change from Tuesday to Sunday. Before I ending, I request our chairpersons of the session, the president of the Oncology Club, Professor Dr. M. Hai sir, to conclude the session. Thank you, sir. Thank you very much. Sir, is he not? Before that, please, Shorna, please show the four winners. Shorna, please show the four winners.
Ma'am, wait a minute.
Shorna, can you not show the poll winners?
Now I'm sharing the winners.
Okay. Yes, previous winners are Dr. Mala Boni, Dr. Shushmita, and Aisha Siddiqui. Yes.
Congratulations to all winners.
Please keep your phone number in the chat box. Hi, sir, please.
Okay, thank you, Shana.
Sir, please.
For a few minutes, I was out, so I couldn't see. I didn't the last person part of the session. But in any case, we had a very nice discussion today and on a very important subject. Cervical cancer is very, very important for countries like ours. We are losing lots of our mothers and sisters because of this disease. So I hope we have learned quite a lot to try to, with all our efforts, to eliminate this menace. The WHO has called this. Hopefully, we shall be able to do it. So thank you all once again. I'm happy that lots of people have Sahana found could make a century today also.
Thank you, sir.
We are
Thank
happy.
you.
Thank you, Dr. Santosh
Thank
Menon.
you. Thank you so much. Thank you.
Nice
Pleasure.
Thank you, sir.
Thank you. Okay.
Also,
Yes, sir.
Annie Catherine is one of us for a pretty long time. So hopefully, thank you all very much again. Goodbye.
Good night. Yeah. Thank you, Dr. Shana.
Wish you all a good health.
Thank you.
Yes, sir.
Thank you.